I'm Linda May. I'm going to get started because I have quite a few slides. So the references and what I used to create this is from the American Geriatric Society. They actually just came out in their journal in March with an update on the vaccines. And the travel vaccines I used was from their guide. So we're here to talk about immunization and immunizations. The goal after this talk is that you'll be able to identify what the ACIP is, identify and comprehend the adult immunization schedule, and we're going to focus on older adults. And we're going to compare and discuss regular vaccines as well as travel vaccines. So the ACIP stands for Advisory Committee on Immunization Practices. Honestly, I didn't even know they existed before I started this talk. In residency, we're trained about vaccines, how to give them, when to administer them, but we're not really trained about how these vaccines are put and implemented and about the recommendations, like how it all comes to be. So one of the key players is the ACIP. It's a group of medical and public health experts, although not all of them are experts, that develops and recommends vaccines to control diseases in the United States. The recommendations stand as public health advice, and they're given to the CDC, and then the CDC issues their statements afterward. It was established under Section 22 of the Public Health Service Act, so as long ago as 1944 is when this committee came to be. So who is on this? Well, it's 15 members. They're selected by the U.S. Department of Health and Human Services Secretary. 15 of them are voting, and they're responsible for making the recommendations. So 14 of the members are experts in vaccinology, immunology, pediatrics, infectious disease, family medicine, internal medicine, lots of different backgrounds, and they're not necessarily all doctors. They could be nurses, researchers, scientists. What's interesting is that one member is actually a consumer. So doesn't have to have any medical or scientific background, just a consumer representative, and they provide perspectives about the social and community aspect of the vaccinations. There are 8 ex officio members who are non-voting, and as well as 30 non-voting members of liaison organizations. And obviously people that are members of pharmaceutical companies or have a clear conflict of interest are not allowed to serve on this committee. They have 3 meetings each year. It's held at the CDC or the Center for Disease Control and Prevention in Atlanta, Georgia. The meetings are open to the public. You can view them on webcast. And its purpose is they discuss any recent outbreaks of vaccine-related diseases. Members form different committees regarding certain vaccines, and they present the research they found, which could include clinical trials, as well as just the vaccine's effectiveness and safety. And they also look at the manufacturing package insert information of the vaccine. So all of this is discussed at these meetings when they're reviewing current vaccines and potentially new vaccine recommendations. When they make the recommendations, they're going to focus on the safety and effectiveness of the vaccine. So they're only going to be looking at vaccines that were approved by FDA. They're also going to look at the severity of the disease that the vaccine's addressing. So ideally, they're going to focus on diseases that have long-term implications, like they could cause chronic health problems or death. So these are what they focus on when they're looking at diseases that could be prevented by the vaccine. In doing so, they're going to look at also the number of people that could potentially benefit from the vaccine. It's important to provide the most benefit to the most people. And they're going to look at how well a vaccine works depending on what age the person is, because as we'll talk later, age does depend on the efficacy. The immune response is going to vary depending on what age. So what we're going to focus on are immunizations for older adults, those 65 years or older. We're going to focus on the influenza vaccine, the pneumococcal vaccines, the herpes zoster vaccine, tetanus, and then a few of the travelers' vaccines that the AGS brought up. So first we're going to talk about influenza. And when we talk about this vaccine, what I'd like to put forth is the general precautions when we're discussing these vaccines, because they're going to apply for all the vaccines. I might sound like a broken record because I'm going to have to reiterate them with each vaccine, but with any vaccine, you shouldn't administer it if you've had a prior anaphylactic reaction to the vaccine or any of its components. And anaphylaxis is not nausea or vomiting. It's tongue swelling, airway swelling and closure, like severe systemic reaction to it. I know some people say nausea, vomiting, and that's the vaccine reaction, but the ones that we refer to when we're talking about anaphylaxis are the ones that are life-threatening reactions. Or if you've ever developed GBS or Guillain-Barré syndrome to any vaccine component or vaccine. So this is an immune response that the body mounts against the peripheral nervous system. It affects the nerves, and ultimately it affects your breathing and can cause the person to be needed to be put on a ventilator. So that's why it's important to document and to know if someone's had a reaction like this to a vaccine. You also don't want to give any of these vaccines if a person's having an acute or moderate illness. So you want to wait until their symptoms resolve. In general, inactivated vaccines, you don't have any problems giving them to most people. It's the live vaccines where you have to worry about if someone's pregnant or they have, a depressed immune system, such as cancer and other conditions. And there is a website that you can go to report all clinically significant vaccine reactions. So we're going to talk about influenza. It's a contagious respiratory illness caused by a flu virus. 5 to 20% of U.S. residents get the flu each year, and more than 200,000 people are hospitalized as a result. So flu season typically starts in the fall and peaks in January or February. The CDC monitors the activities of the flu, and they produce weekly reports that range from October through mid-May. Most healthy adults are infected or can infect other people one day before their symptoms start, up to 5 to 7 days after they've been having symptoms. And complications can be quite severe, especially in the elderly, and these include, as ear infections and dehydration, which is milder forms, to the more severe, like pneumonia. And the illness usually lasts about 1 to 2 weeks. So the CDC monitors all flu. As you can see here, it's not as evident here, but here the green line with people over the age of 65, this is how many people have been hospitalized based on age. And so elderly are more at risk of being hospitalized. I also wanted to note that it's still serious in children. Here is the amount of deaths, pediatric deaths, because of influenza. And then we have a map of flu activity so far for this year. And Texas is in the low range, so not high, but not minimal. So the indications for the vaccine, pretty much everyone, especially elderly people above the age of 65. But the American Geriatric Society is saying we should also look at elderly who have high-risk conditions, such as chronic cardiovascular disease, chronic lung diseases like COPD and asthma, any immunosuppression, such as cancer, where there are treatments, metabolic disorders like diabetes, people with hemoglobinopathies or blood problems, and especially residents in nursing homes or long-term care facilities, and any household contacts of high-risk adults. Basically everybody. So this is a one-time dose. It's administered annually, and the only class that's approved for administration in elderly adults is the inactivated form. So you don't want to give activated. Contraindications, like we mentioned earlier, is any severe anaphylactic reaction, if they've had Guillain-Barré or GBS because of the vaccine, and in this case, especially if they're allergic to any component like eggs. As I said before, don't give the live vaccine to people above the age of 50. And the vaccine is a trivalent vaccine. It's given in the deltoid muscle or your arm, and it's administered just prior to flu season is ideal, so as early as October, but you can give it as late as May, which is the end of the flu season. There's actually a high-dose formulation now for elderly. It's got 2 strains of influenza A and 1 strain of B, and the reason it's aimed at elderly is because they did some research, and because it has 4 times the amount of the hemagglutinin for each strain, there was a higher antibody response and higher CR conversion in elderly, about 24% greater. So that's why we're promoting it for elderly. You know, the downside is it does have the tendency to elicit more reactivity at the injection site, so more soreness. But generally, it's well tolerated. Other side effects could be hoarseness, sore red eyes, cough, itchiness, fever, muscle aches. So when you're discussing the flu shot with your patients, because I know a lot of elderly patients are resistant to the flu shot and say, well, why do I need it? I really don't want to get it this year. I would focus on the fact that it's not your common cold. It's a serious respiratory illness disease. I mean, you saw earlier how many people are hospitalized and how many people die from it. So that's what I would tell them if they're resistant towards it. And I would also say that it's something that spreads easily to other people, and it can be especially severe and vulnerable people. So that's another reason why people should get vaccinated. And it has been proven in studies to prevent death, hospitalizations, and pneumonias. So it's very important. We're going to move from influenza to another respiratory illness, which is
So what do you suggest we say to the patient who says, oh, I got that vaccine one time and it gave me the flu and I'm never getting it again?
Well, I was thinking about that when I was looking at the side effects because they are very similar. I mean, they didn't say that a side effect was the flu, but if you look at it, hoarseness, tired eyes, cough, itchiness, fever, and aches pretty much sounds like the flu, even if it's not. But I would say that the risks outweigh the benefits, that even if they're going to get some muscle aches or fever or feel a little crummy for a few days, that, you know, ultimately they're preventing death and hospitalization and other complications from it.
Right, and I'll usually tell people that's just a sign your body's kind of responding to the vaccine and making the antibodies. Like the vaccine, the flu is dead in the vaccine, so it cannot give you the flu.
Right.
And that reaction is more common the first time you get the vaccine, but much, much less common on subsequent administration. So I usually tell people, you already did the hard part, and now if you just keep getting the flu vaccine, you're not going to get, likely not to get such a reaction. And then I often use the guilt card of the grandchildren, so I'll say, well, I know you're not worried about yourself getting the flu, but if you watch your grandkids or, have other family members that are chronically ill, it's good to get the shot so that you don't pass it on. I know you wouldn't want to pass it on to your, 2-year-old grandson. So I don't know, I try to use any means necessary to convince people to get the flu shot. But that's just something I hear probably like 1 out of 4, 1 out of 5 patients says, oh, I got it one time and I got horribly sick. And
so I don't get it anymore.
So I'm never going to get it again.
All right. So the flu, one of the new changes was the higher dose. And we're going to talk about another vaccine that had some changes, which is targeted towards Streptococcus pneumonia.
I have a question. For elderly people, they commonly get this vaccine, in the senior center or not necessarily in hospital situation. They don't even realize, they just go there, they got vaccinated. They don't realize, they got, what kind they got it, whether it's influenza or other kind of things. Let's say I take care of my parents, I go to hospital or the emergency room, they first ask me, does he got the flu vaccine or not? I said, I don't know. So if hospital gives them another dose, is there any danger there, or
no?
It doesn't matter, right? Just give it to them again.
And in general, with all the vaccines, there's no danger if you don't know to giving it.
So you can give a year, give 2 or 3 times, it's fine, right? Okay. I never know.
They're protected 3 times more than everybody else.
So Streptococcus pneumonia is another leading cause of serious illness. Some forms, when people are infected, could include bacteremia, meningitis. Most commonly, we see pneumonia. It is an organism found in the upper respiratory tract of most people. And pneumococcal disease occurs most often in elderly people and those that have a predisposing conditions such as like pulmonary diseases like asthma, COPD, or if they've had their spleen removed either from hemoglobinopathies like sickle cell. There's about 40,000 cases of bacteremia in the U.S. annually, and fewer older adults become infected with the disease when the children they're around have been vaccinated for it, usually in the form of a Tdap vaccine that they get during their immunizations. Another benefit that I would stress to patients that are resistant about the vaccine is that Medicare Part B will cover the full cost of the vaccine. So it's not just a copay cost, they'll cover the vaccine in full. So this one has an update. There's 2 vaccines now to prevent against Streptococcus. One is pneumococcal conjugate vaccine 13, or Prevnar is what we call it, and the other one is pneumococcal polysaccharide vaccine 23, or Pneumovax is what we call it. Prevnar prevents against 13 strains, and Pneumovax prevents against 23. Both prevent against meningitis and bacteremia, but Prevnar is the only one that prevents against pneumonia. And these should not be given at the same time. So Prevnar came about in 2011. The FDA approved it for people older than 50. When the ACIP met in August of 2014, there had been a study in the Netherlands that came out that showed how good it was in preventing pneumonia in older adults. And they actually fast-tracked its use. So when the ACIP met, they decided that it should be recommended along with the Pneumovax. So now it's part of the schedule, and they're actually going to look in 2018 at updating it, because right now what we have is just the 2 shots, and then they're going to look at if boosters should be needed or how the dosing will change. So until 2018, this is how we're going to administer it. We're going to administer to everyone over 65 years of age. If they've never gotten either of the vaccines, you give Prevnar first, and then here it says you wait 6 to 12 months to give the Pneumovax. What we've been doing in clinic is just everyone a year later gets it. If they're in the category that they've already had the Pneumovax, because remember, Prevnar is pretty new. So if they've already gotten a dose of Pneumovax, then you want to give the Prevnar a year after. And for those who have needed a second dose, so this is anyone who's gotten the Pneumovax before age 65 for reasons such as they had their spleen removed or other comorbidities we'll talk about in a second. If they need a second dose, they're saying give Prevnar first and then give the second dose a year later or sooner if it was greater than 5 years after the first dose. So those people that already had a dose before 65 is the people that had chronic renal failure or nephrotic syndrome, or had their spleens taken out because of sickle cell disease or any immunocompromised conditions. But in general, by age 65 is when you would be needing this series, and most people haven't had to have a dose before then. Contraindications to the vaccination are the ones we mentioned previously, if they've had any kind of reactions to the vaccine or components at a prior administration. If they're sick, you want to wait till their symptoms resolve. And the side effects are the same. It's the soreness at the injection site, and you can get mild fevers, fatigues, headaches, or chills. Another vaccine that we're targeting for the elderly is the herpes zoster, the shingles vaccine. So 1 out of 3 people will develop shingles in their lifetime. There's about 1 million cases a year. Anyone who's recovered from chickenpox has the risk of developing shingles later on. And the risk increases as you get older. So about half of cases of shingles occur in people ages 60 or older. And people typically have 1 episode in their lifetime, although if you're really unlucky, you can have 2 or 3. It's caused by the varicella zoster virus, and it stays dormant in your body until you have like decreased immune system from maybe say you're really sick. Then you have the risk of it reappearing. And it can reactivate years later. So shingles is a painful rash. It usually affects one side of your body. As you can see on the diagram, usually the trunk area is affected, but you can have it appear on your face. The rash is going to have blisters that typically scab over in 7 or 10 days and then clear up fully within 2 to 4 weeks. Before the rash develops, people can say that they have this tingling or burning sensation in the area. It can also affect your eye and cause loss of vision. Other symptoms that they can complain about are fever, chills, upset stomach, and then one of the more severe complications that we worry about with anyone with shingles is post-herpetic neuralgia, which is that the burning and tingling doesn't go away and can stay and can recur. So the vaccine, called Zostavax, was licensed in 2006 and then was recommended by the ACIP in 2008. It's a live virus vaccine, so you do have to take that into consideration. You don't want to give it to anyone that's immunosuppressed. And so the CDC is saying that it's approved for those 60 years and older. The FDA approved it for those 50 years or older. And we're gonna get into the age difference in a little bit. They used to say in the past that you had to test for varicella immunity or do serologic testing, but that's gone by the wayside. You don't have to do that. Also, you don't have to have had chickenpox or say you had chickenpox when you're younger to get the vaccine. Because believe it or not, a lot of people have had chickenpox younger and not even realized it. And we based this off a study where they did serologic testing and were able to prove that a good deal of people that had said they never had chickenpox were actually still exposed and have a risk of developing shingles later. If you do have shingles, you can still get the vaccine. It'd be better to wait until the symptoms and the rash have resolved, but I know that's a common question that people ask. Well, if I've had shingles, would it be worth it to have the vaccine? And yes, because it still decreases the risk of you getting it later. Or if you get it, decreasing the severity and the risk that you might get complications like post-herpetic neuralgia in the future. So those who shouldn't receive the vaccine, anyone that's had a reaction to prior vaccines, anyone with a weakened immune system, those with AIDS undergoing treatments or T-cell counts or CD4 counts less than 200, those with treatment or having steroids, and anyone that might be pregnant. It's given in the upper arm. Side effects are the same: redness, soreness at the injection site, headaches. It can reduce your risk of shingles by 50%, and it can reduce the risk of getting post-herpetic neuralgia by 66%. Medicare Part D will cover the vaccine, but you will have to pay a copay. Part B doesn't cover it, and Medicaid may or may not. But most private health insurance plans cover it for age 60 or older, and some plans cover it from 50 to 59. So as far as when to give it, yes?
I have a question you may not know the answer to, so I apologize if you don't. Do you know how long people need to be on steroids before they can't get it, or how long they need to be off steroids before they can get it?
I
I don't know what
sorry.
constitutes.
I can look it up, but I don't know how long they can be off the steroids. Or need to be off the steroid before getting it. Because I know if they're on it, then they shouldn't get it.
Right.
So in adults that are age 60 or older, the efficacy of the vaccine, as with all vaccines, tends to wane after 5 years. So protection after 5 years is uncertain. That's why the CDC is promoting age 60 or older versus the FDA that's in age 50. And as a medical doctor or physician, I would promote waiting until at least 60 years old, just because then you know you'll have more, the efficacy will last longer. And as additional data becomes available, they're going to reevaluate their position on vaccination, whether we need another vaccine or it's just a one-time, and basically they're going to look at the complications from herpes zoster.
There is my understanding that the vaccine is not as efficacious for people once they hit their mid-80s and above, and that you should think about possibly not vaccinating them at that point. I don't know if you came across anything.
I came across that it wasn't efficacious at that age, but I didn't come across whether like any stance on not vaccinating. But I did come across several articles mentioning the efficacy that after 5 years it's waning and that they want to look at it again in a few years.
Okay.
And I suspect that the ACIP is probably going to recommend more doses
Okay.
because with all the research for 5 years.
Oh, this wasn't that they've had it before. This is just if it's their first time, once they're that old, not to do it. But I don't know if that's true or not. It's just something that I've been told at one point. So.
Is that more because it doesn't work or because it's
Because
a
it
live
doesn't work,
vaccine?
is what I've been told, so I don't know.
There
I
were
just
some
was wondering if you'd
studies-
come across that.
There were some studies that said it wasn't, the efficacy wasn't as well older.
Okay.
But no physician saying don't give it.
Okay.
So now we're going to talk about tetanus, diphtheria, and pertussis, but I'm going to focus on pertussis because that's what affects most of our elderly patients. Pertussis is a respiratory illness. It's commonly known as whooping cough, and it's a very contagious disease. In the early stages, it looks like a common cold, and it's the later stages with the more severe symptoms that makes it get diagnosed sooner. The coughing fits can last up to 10 weeks, and in China, it's called the 100-day cough. Treatment is with antibiotics, and the rates of pertussis have declined by 95% since we introduced the vaccine. So in the early 20th century, there was routinely about 100 to 200,000 cases annually. This dropped to about 5,000 in the 1990s. And since the beginning of the 21st century, the rates have slowly been rising. You had a peak of 48,000 cases in 2012. The reason is multifactorial. Part of it is that we're having children not be vaccinated, and that contributes to it. Also, they went from a whole cell pertussis vaccine to an acellular pertussis. The reason they did that is the whole cell had a risk of greater reactions and you had higher fevers as part of the side effects, so that's why they were more towards the acellular. And but the downside is that the duration of protection with the acellular is shorter than the whole cell. And the rate of shedding asymptomatically is higher. So this prompted, the increasing cases of pertussis prompted the CDC to make different recommendations as far as vaccination, and to include a Tdap booster for adolescents and adults. So since 2012, the ACIP has been recommending a one-time booster, and this is for all adults age 18 or older with no upper age limit. The benefit is to try and decrease the incidence of pertussis because it's a very, in susceptible children, it's a very severe life-limiting disease. For those who are 65 and older who have not received the Tdap booster, they say just give it immediately. There's no certain age that they have to give it. And it doesn't matter when they had their last tetanus, because the tetanus shot is updated every 10 years. If they've never had their Tdap, then just give it. And then so far what they're saying right now is that the one-time booster should be enough. They are going to meet again to make further recommendations, but for now you just need the booster once. And then after that, you still need to keep your tetanus up to date every 10 years, but it can be just the regular tetanus vaccine. So the Tdap is an inactivated vaccine. Contraindications, apart from the ones that we've been mentioning earlier with all the vaccines, if they've ever had encephalopathy, within 7 days of administration. Encephalopathy being coma, a decreased level of consciousness, or seizures. And then the precautions are the same as far as if they're sick, wait till their symptoms resolve, if they've ever had GBS within 6 weeks of a dose. The only difference is that another precaution would be anyone with a unstable neurologic disorder or seizures or encephalopathy. They're saying you need to find a stable regimen and wait till it's stabilized before considering the vaccine. Side effects are your typical side effects of swelling, redness at the site, fever, and soreness. So now we're going to shift gears and look at travelers' vaccinations. I don't have all of the vaccines listed, I just have the ones that the American Geriatric Society was focusing on. So I'm sorry, typhoid is not here. What they are recommending is that you make an appointment with either a travel clinic or your primary care doctor at least 6 months before you travel so that you can get the vaccines. We're going to talk about the MMR, meningococcal hepatitis, and yellow fever. So you can't talk about measles without talking about the recent controversies that have happened in the news. So before, the way measles was brought to the U.S., it was mostly from international travel from unvaccinated people who became vaccinated in other countries. It's a common disease in many parts of the world, including Europe, Asia, and the Pacific and Africa. 20 million people get it year-wide. 146,000 people die each year. So anyone who is not protected against measles is at risk of getting infected when they travel internationally. And this is assuming that you haven't had your childhood MMR vaccines or been vaccinated. There was the recent outbreak in 159 people from 18 states in the District of Columbia were reported to have measles. And most of the cases, about 74%, are linked to the outbreak in the amusement park in California. So it was a record number of cases that happened since 2014, 668 cases. As you can see, before that, it was relatively calm. It's the greatest number of cases being reported since 2000. Measles is a very serious disease. It's a virus that causes rash, cough, runny nose, but it can also lead to brain damage, death, seizures, pneumonia. Mumps and rubella are also viruses. They cause the same fevers, headaches, muscle pains. Mumps can also lead to sterility, and rubella, if a woman's pregnant, can lead to miscarriages and severe birth defects. So any adult who doesn't have evidence of immunity against measles should get 2 doses separated by at least 28 days. So that's why you want to see the travel clinic months before you travel. Contraindications would be any allergies to previous vaccines, if you're sick, and to be cautious of people who have cancer, recent transfusions, or steroids. So this is why we're promoting vaccination right now. This is why everyone's focused on vaccine awareness, and I was reading in the headlines that California is actually looking into making it mandatory to have vaccines, that if your children go to school, they have to be vaccinated. Hopefully this catches on with other states, because as you can see, we've had significant outbreaks and people have died just because people didn't want the vaccine. Another travel vaccine is aimed at preventing meningitis. So meningitis affects 5 to 10% of the population. Meningitis is found in 5 to 10% of the population as carriers. It's highest in the sub-Saharan Africa. It's actually a meningitis belt. It's highest during dry season, December to June. And the rate can be as high as 1,000 cases per 100,000. 60% of cases occur in adolescents and adults. Meningitis, the disease occurs about 1 to 14 days after exposure. And it usually presents as meningitis in more than half of the cases. So you'll get your sudden headaches, fevers, neck stiffness, and pain that can progress to nausea, photophobia, vomiting, and altered mental status. 20% of people can also bring up with sepsis. And diagnosis with a lumbar puncture, it can be potentially fatal. It is considered a medical emergency. So the ACIP recommends vaccines for travelers going to countries where the disease is endemic. And some places need proof that you had the vaccination, especially if you're traveling to Mecca during the annual Hajj and Umrah pilgrimages. So that's the only case where you have to provide proof. The vaccine itself, the polysaccharide vaccine, can be used in people above the age of 55. It's inactivated, so you can give it to immunosuppressed. The vaccine is normally given during the childhood series, but those older than 55 should be revaccinated if it's been greater than 5 years since their last vaccine. And then again, the only place that you have to prove that you actually were vaccinated is if you're going to Hajj. Contraindications are similar to all the other contraindications we've listed with the other vaccines, and side effects are the same: the pain, redness or soreness of the injection site. Hepatitis A is also another disease that you have to worry about when you're traveling. It's a liver disease. It could potentially have no symptoms, so if you do have symptoms, you could have jaundice, tiredness. It's spread by fecal oral route, and vaccines are available for long-term prevention of those greater than a year or older. And when you're traveling, they say to emphasize just good personal hygiene and proper sanitation to prevent the spread. Anyone traveling for any purpose, frequency, duration of time, anyone's susceptible. And maps aren't really good at showing where you're traveling if you need it, because it can happen in developed countries. There are outbreaks due to food contamination, so that's why they didn't want to specify a certain area. The CDC is saying that everyone should be vaccinated. And expert travel clinicians are saying that it should be regardless of your destination. If you're greater than 40 years old or immunocompromised, you should receive the initial dose of the vaccine along with the immunoglobulin at a separate injection site. So that's why older adults are generally going to receive 2 vaccines. It's not contraindicated to give the vaccine if you're already immune, because they're saying that the risks outweigh the benefits. And when you give the vaccine, you don't have to test for serologic immunity afterwards. Hepatitis A vaccine, the cautions are the same as before with the other vaccines. If you have any allergic reactions to any components, if you're sick, and the side effects are the same as pain and soreness at the injection site. Hepatitis B is also a virus that affects your liver. If you do have signs and symptoms, it will be similar with the fatigue, anorexia, nausea, vomiting, and jaundice. The main difference is that acute hepatitis B can turn into chronic. In 30 to 90% become chronic in young children and about 5% during adulthood. So hepatitis B should be administered to all unvaccinated people traveling to areas that have intermediate to high prevalence. The vaccine should be considered in those regardless of destination, depending on the risk. It's administered in 3 doses, so 0, 1, and 6 months is when it's generally given. And I know when you're traveling, you don't have often that much time before. So if it needs to be accelerated, you give it at day 0, 7, 21 to 30, and then you give a booster in a year. But ideally, it should be given 6 months before travel, or at least the first 2 doses. The cautions and side effects are the same with hepatitis A and with generally all the other vaccines. Yellow fever is the last travel vaccine we discuss. It's transmitted by an infected mosquito. It occurs in sub-Saharan Africa and tropical South America. So the risk is seasonal. In Africa, it's at the end of the rainy season and the beginning of the dry. And in South America, it's highest during the rainy season. There haven't been that many cases. A total of 9 cases were documented in unvaccinated travelers. But if you do get it, it's pretty fatal. 8 of the 9 died. There's only 1 documented case in a vaccinated traveler from Spain, which happened in 1988. The risk of developing it during, like, say, a 2-week stay, it's 10 per 100,000 West Africa and 1 per 100,000 South America. So it's lower in South America because the mosquito that that transmits the virus between monkeys and the forest canopy, they usually don't come in contact with humans. So that's why West Africa, you have a higher risk of contracting the fever there. The illness is asymptomatic, but symptoms can occur and it'll be like a typical flu. And its treatment's usually symptomatic, but 15% can progress to a more severe form. It is a live vaccine. It's recommended for those 9 months or older. And because there are serious adverse effects from the vaccine, they're saying to only recommend it in elderly people who are at a really big risk of exposure, or if they're traveling to someplace that absolutely requires it, which we'll list those countries in a second. The adverse reactions, the key adverse reaction is the yellow fever vaccine-associated neurologic disease. So it could present like Guillain-Barré syndrome and be autoimmune, affecting like your peripheral nervous system. You could also get encephalomyelitis, or that altered level of consciousness we were talking about, and Bell palsy. So you can have something as mild as Bell palsy to something as severe as Guillain-Barré. It's contraindicated in those younger than 6 months, and those who've had reactions to eggs, proteins, or gelatin, any immunocompromise. And they did studies on this vaccine in elderly adults. Older adults were more prone to have the adverse reactions. So it's 8.3 per 100,000 doses compared to 4.7 in the general population. So if travel is unavoidable and you're going to one of those places that requires proof, then we're saying you should give the vaccine. Otherwise, the AGS is saying it's not ideal to give an elderly people. So countries that do require proof are the ones listed, and it does actually, there's a yellow vaccine form similar to this that shows that you have proof, and they will ask for it when you're traveling. So points I would stress when you're talking to your patients about vaccines and in an effort to improve compliance rate, I would inform them that older adults are more at risk for catching these illnesses and for getting serious complications from them. There are newer vaccines, so even if they say that, oh, well, I got it prior to this, I would emphasize that the newer vaccines are more effective and they're better than the earlier versions. As well as what we discussed earlier, that immunity can fade over time. Efficacy is not permanent, and they may need to have boosters or be vaccinated further on down the line. Those born outside the United States should also be encouraged to have vaccinations, because some of them have been vaccinated as children. And I would emphasize that the vaccines can be covered either part or in full. Influenza and the pneumococcal vaccines are covered by Medicare Part B, and the zoster vaccine is covered by Medicare Part B with a copay. Does anyone have any questions?
I was just gonna say with regard to yellow fever, what I've noticed is a lot of the travel companies are giving patients, or giving the travelers information about, like, we expect your risk of exposure to be very, very low. For example, if they're doing a cruise along the exterior of South America, they're not likely to get interior and really be at risk. And so they'll kind of say, we don't routinely recommend that our travelers get the yellow fever vaccine. But on the other hand, if they're doing like an inland river cruise and they're gonna be like going through the jungle, it will pretty explicitly say, like, we highly recommend that the traveler gets the yellow fever. So, I mean, I think it's always fair. I mean, I'm just really honest with my patients. Like, I think if hear what you're going to be doing. Like, are you going to be like hiking through the mountains, or are you going to be like going to Rio de Janeiro and shopping? So I think it's good to find out what they're going to be doing. And then generally, yeah, for Africa, I would say it's higher risk. And so generally, you would probably, even though there's a risk to the vaccine, you would probably recommend it.
Any other questions? Okay, well, thank you.
Can you fill out an evaluation, please?
And make sure you guys sign in. Or you can get out of the group, but you wouldn't sign anyway.
She's got her, Joe has to see.
Oh, she's, sorry. Where are those? I thought they were.
I went back downstairs. I just realized there were two orders I forgot to put in, or make sure it got put in. One's interesting.
Sugar on our uniform, and then a physician had to say, and it was a long, long time.
Much better. Whatever it is out there right now.